I think I call upon the next speaker, Dr. Sandra, who's done a lot of work in myopia. And we also have set up a myopia clinic in the Aravinda Hospital, Coimbatore, because we've seen the increase in number of cases. So we will share our experience in what's happening in the myopia clinic. Thank you.
Thank you so much, ma'am, for the kind invitation. So I'll be talking about two of the most current topics in pediatric ophthalmology nowadays, being myopia and amblyopia management. So this slide shows just a sneak peek of the myopia predictions between 2090 and 2022. You can see that across the year, we have been seeing a more increase in the number of new myopia cases, that is the red pointer. And also, if you look at the time trends on the prevalence of myopia in India, this model is for 2050. And you can see that it increases to around 31% in 2010, 40% in 2040, and around 50% in 2050. And this can be brought down to around 32% with myopia interventions. And that is a very big thing. So is it controlled only by genetics? So a lot of genetic factors are there in the implicated in myopia. And also we know about the parental association with a higher risk of myopia, 2 times if one parent is myopic and around 5 times if both the parents are myopic. But the dramatic increase in myopia prevalence over the last 50 years cannot be explained only by genetic factors. So environmental and behavior factors are definitely there. So in the past, our human ancestors were more looking at distance, but only in the last 100 years, they have started more of looking at the near, and this has led to the dramatic increase in myopia. So increased time spent outdoors can prevent or delay the onset of myopia by around 30%. And definitely, that goes to say that there should be less time spent on smartphones, near digital devices, and near tasks as well. And the viewing distance should always be less than more than 20 centimeters. So the smartphones and tablets, if we held it very close to the face, that can result in progression of myopia. And always we have to remember that we have to follow the 20-20 rule when we are using the gadgets. So with these in mind, a lot of research has been underway in myopia over the last few years, and this is the consensus statement which has been given by the CPOS, which most of the pediatric ophthalmologists will be having in hand, and it gives forth the behavior interventions, optical treatment, and the pharmacological interventions which have been proven to have an effect on myopia control. And what does not work also has been elucidated, and one of it is the blue light blocking glasses, which really does not have much effect. So myopia is multifactorial, the main factors being age, ethnicity, gender, and parental myopia. And there are several minor factors which include circadian rhythm, ocular factors, education, near work, time spent outdoors, rural, urban, etc. Another thing that we keep hearing nowadays very often is the peripheral refraction. So what is this peripheral refraction and peripheral hyperopic defocus? So this is a refraction that we do like offset from the center by 20 degrees nasal and 30 degrees temporal. And why is this so important? Because visual signals from the fovea are not essential for ocular growth, as has been proven by studies by ablating the fovea. So how do we measure the peripheral refraction? This is by an open field autorefractometer, which has been developed by certain companies, but it's quite expensive, around 8 to 10 lakhs. So the same thing can be done with the help of this is a new instrument which has been developed by the LV Prasad group, which is called as a PAR, that can be fitted on to the retinoscope and you can easily do the peripheral refraction as well. So these are the patterns of peripheral refraction that we see. In emmetropes, it is said that they have a weak relative peripheral myopia, where and hyperopes also have a relative peripheral myopia, that is in the center the focus is towards the behind the retina, whereas in the periphery the hyperopic eye, the focus is in front of the retina. But look what is happening in the myopic eye. In the myopic eye, the center is focusing in front of the retina, whereas in periphery, because of the shape of the eyeball, the focus is going behind the retina. So myopic people, some of them have this relative peripheral hyperopia. So when you are putting them on a single vision glasses, that is your diverging glasses, the relative peripheral hyperopia is worsened. So whenever that happens, that results in progression. So the fact to remember is that whenever there is relative peripheral hyperopia in such eyes, if we put them on single vision glasses, the myopia will continue to progress at a rate faster than what is expected. So then how can we control this? Is with the help of lenses which can create a myopic defocus. So these lenses, currently available ones which are based on this kind of technology are the HALT lenses and the DIMS lenses. The lenses based on the DIMS technology called as the MyoSmart lenses, they have a central 9 millimeter clear zone and they have a peripheral honeycomb pattern. So that creates the peripheral myopic defocus, and in theory it helps to reduce the progression of myopia. Similarly, the SLR Stellest lenses also are based upon the HALT technology, and they create a volume of defocus in front of the retina and helps to retard the progression of myopia. So these are the studies of the DIMS lenses of the Hoya group, which have a 7-year study, and they said in that study that the progression of myopia is only around minus 0.15 diopters per year, or about 0.1 millimeters per year on an average, and the treatment has been sustained over the 6-year period. On comparison of the DIMS and the HALT lenses, both are of polycarbonate material, and so when we prescribe these lenses, we should also know when they are working. So what is the target progression? The target progression cannot be the same for all age groups. In the age group less than 9 years, the target should be less than 0.5 diopters per year, or an axial length of less than 0.3 millimeters per year. So whatever interventions you are following, if this is being achieved, then that means that your treatment is working. Similarly, over the age of 9 years, the target myopia progression should be less than 0.3 diopters per year, and the axial length change being less than 0.15 millimeter per year. So coming to atropine in myopia, it slows progression by about 50 to 60%, is what all the studies wise and with our own experience. Effect is better in the second year than the first. And as of now, currently in India, we are getting only the 0.01 the percentage, but very soon probably the 0.05 will also be available. But the thing to remember about the higher percentage is that the risk of rebound is always there when so the guidelines for stopping will be more difficult the more higher the percentage of atropine that you are using. And the sustained effect on 5-year follow-up is also there. But 20 to 30% of people need higher doses for myopia control, and also 10% of the children will be non-responders even to high-dose atropine. So this is the IATM study which has been done in 3 centers, RP Center, Narayana Nethralaya and Shankar Nethralaya, which was a multicentric double-blinded study to evaluate the efficacy of 0.01% atropine in reducing myopia progression in Indian children, because most of the previous studies are from Singapore, and they proved that the difference in spherical equivalent was about minus 0.16 in the atropine group and minus 0.35 diopters in the placebo group, and this was statistically significant. So this proves that it works well in Indian eyes as well. So this is the impact myopia management guidelines as given by LVP. So we have to first identify the true axial myopia. It's very important. So for all these interventions, we should not choose a pathological myopia or syndromic myopia or even ROP treated myopia. It does not work in those conditions. We have to map the risk factors, pick out the progressive myopes, advise appropriate myopia control strategy, and then counsel, combine and monitor regularly. So with these in mind, the myopia clinic will do the risk assessment, clinical evaluation, and give a customized treatment plan. And we should include only simple myopes, age group 6 to 14, with a stable cylinder. If there is any doubt about the cylinder, we always have to do a topography and confirm. Key points in history will be the age, the parental myopia, because age means once the myopia starts at around 6 years of age, it is very different from starting myopia at the age of 11 or 12. Near work, outdoor time, prior progression and prior treatment, and also educating staff and the parents are very important to discuss the various treatment options available. So evaluation will include dynamic refraction including duochrome, PV analysis, MEM for accommodation, non-contact axial length, keratometry, cyclorefraction, and indirect ophthalmoscopy. Role of axial length is paramount. It's the most important metric to monitor, which should be documented for all the kids, because the repeatability of refractive error measurement only with subjective refraction can be around plus minus 0.5 diopters, even between people. But for eye length measurement, the repeatability is between 10 to 50 micrometers. So definitely it's much more effective indicator than just relying on the refractive error alone. And these are the non-contact biometry. Various types are there. Your Zeiss IL Master or the Hoya, the Lenstar machines. They also help to, and these Lenstar myopia machines can even give a progression chart based on which we can choose the interventions which will be appropriate for the child. Cycloplegic refraction with full cycloplegia is important because we should not over minus the children. The correct focus on the frames, fit and centration is equally important. So this is our study with the smart glasses, which we have around 9 months follow-up till now. Prescribed 71 glasses, out of which 30 patients have come for 6 months follow-up. And before we gave them on the MyoSmart glasses, 23 were progressive myopes. 7 of them we started because of a very strong family history and young age. So out of these, none of the children require a change of glasses so far, but the axial length is more than expected rate in around 7 of them. So 5 of them we have added a combination of low-dose atropine, and marginally reduction in axial length is seen in around 9 patients. So achieving compliance with the parents is very important. The most important thing to confirm whatever you do, the environmental and the behavior modifications are paramount. Unless they achieve that, the interventions will not work. So coming to amblyopia, the first step will be to correct refraction, glass prescription, rule out organic causes. The traditional therapy was always the gold standard, but the pitfalls can be poor adherence, decreased compliance with increasing age, psychosocial impact of patch, light sensitivity with atropine, and it does not really achieve true equalization because it does not address suppression and it does not encourage simultaneous perception. And amblyopia is not only a visual acuity loss, because patching can target only the visual acuity improvement. It cannot target the depth perception, binocular vision and eye teaming. And there are a lot of other difficulties along with visual acuity loss and amblyopia, including inability to fuse at near, double vision, blurry vision, headache, poor tracking, poor processing. And so the newer concepts would include binocular vision training, where we encourage both eyes to work as a team with a goal to break suppression, improve reading ability, better academic performance and better sports performance. So the concepts based on these are the perceptual learning and the dichoptic training. So just for a very short summary, the binocular therapy using dichoptic stimuli will present two stimuli to either eye with a difference in contrast, the contrast being reduced in the normal eye. And as the visual acuity improves, the contrast will be gradually increased. So this Amblygo is based on this principle, where the patient has to play games for around 30 to 40 minutes for at least 5 times a week. And initially the improvement can be seen in around the first 2 weeks and the sustained improvement around 6 to 8 weeks. So you can target patients even at the age of 5 years with foveal fixation, no tropia, full refractive correction. If there is high myopia, you give a contact lens. There should not be microtropia or eccentric fixation. So in our experience, all the green are the patients where we have seen at least a 2 logMAR line improvement, the blue where we have 1 logMAR line improvement, and the red where we did not have any improvement. They are a minority. So till now we have completed 21 patients, out of which 13 are anisoamblopes, 8 have improvement of 2 lines, 1 logMAR line and 2 no BCVA improvement in anisoamblope. Ametrope similarly, most of them have had 2 logMAR line improvement, but strabismic, there are 2 patients who did not have BCVA improvement, but 19 out of 21 have improvement in BSV and 17 out of 21 have improvement in stereopsis. And perceptual learning is also based on similar principles with the Gabor patches. We are just started with this now, and we had good result in 2 patients with nystagmus. So thank you.